Greetings, everyone, and welcome to the webinar Qualitative Methods Used in AHRQ-Funded Primary Care Research. Before we begin, we would like to go over a few housekeeping items for today's webinar. First, all attendees will be muted for the duration of the webinar in order to preserve audio quality. However, we absolutely hope and anticipate to hear from you through the chat feature in WebEx, which is located in the lower right-hand side of your WebEx screen. We will review audience questions during the Q&A section at the end of the webinar. That concludes the housekeeping notes for today's webinar. I will now pass it to Amy Eden to introduce today's content.
Great, thank you so much, Kayla. And welcome everyone. We are super excited that you've taken time out of what we know are your busy schedules to join us today. My name is Amy Eden. I am currently the acting director for AHRQ's National Center for Excellence in Primary Care Research, which for obvious reasons, we use the acronym usually, and we pronounce that NICE PCR. It's my pleasure to welcome you to today's webinar about qualitative methods used in AHRQ-funded primary care research. And before we get into our excellent lineup of presentations, I'd love to just take a minute to tell you a little bit about NICE PCR. So next slide. Yes, there you go. We have our presentations aren't gonna represent AHRQ findings. Okay, great, thanks. So AHRQ's 1999 authorizing legislation included the establishment of a Center for Primary Care Research that would serve as the principal source of funding for primary care practice research in all of the Department of Health and Human Services. So as such, AHRQ has funded primary care research since the very beginning, but the work hasn't always been clearly distinguishable as a holistic portfolio of work, and thus sometimes isn't easily accessible to external researchers. About 2 years ago, NICE PCR became more formalized with a full-time director. And last year, NICE PCR received earmarked primary care research funding for the first time. Next slide. And so over the past few years, NICE PCR has been working to develop a more coordinated primary care research portfolio and agenda to create more targeted primary care funding opportunities, to support and expand a diverse primary care research workforce, and to build a more robust dissemination strategy. And that is among a lot of other things that we've been doing to make AHRQ's primary care research more visible, coordinated, more comprehensive, and ultimately more effective. Next slide. So this webinar series, Strengthening Primary Care Research, is part of these dissemination efforts. And maybe you caught the first webinar in the series in June. That one was about using large data sets in primary care research. And if you didn't catch it, you can find the recording on our website. Today's webinar changes gears a little bit, and it's about using qualitative methods. It's the second in our series. And we're working on the third webinar, which will be focused on research that includes the innovative use of technology in primary care delivery. So stay tuned to the AHRQ channels for the date and registration information for that upcoming webinar. And today's webinar and the slides will be made available later on the AHRQ website. Next slide. The goal of today's webinar is to demonstrate how qualitative research methods can be used to answer different types of primary care research questions and inform effective design of interventions in primary care settings. The focus today is on the methods used rather than on the findings. So you'll get to hear about how qualitative methods like interviews with patients and observations of patient visits have been used in 3 different studies, and then the different approaches to sampling, recruitment, and analysis, and then some advantages and challenges of using those methods. As a medical anthropologist and qualitative and mixed methods primary care researcher myself, I'm especially excited to hear from today's presenters whose projects really demonstrate the value of using qualitative methods in primary care research. So without further ado, I'd like to introduce the moderator for today's webinar, Andrea Heckert, a health services researcher from Apt Associates with also with experience in qualitative and mixed methods research. Andrea will facilitate the Q&A and discussion, which will take place after all of the presentations are complete. So welcome, Andrea. I'll turn it over to you. Thanks.
Hi, everyone. Before I go into this slide, I do want to say we are monitoring the chat, and we see that some folks have reported some audio issues and also closed captioning. So please know we're on it, and we're working to provide you the responses in real time. Next slide, please. So we have 3 primary care researchers here today. Each one will discuss some of the qualitative methods they used or are using in a recent AHRQ-funded study. First, we have Anna Steves-Reese from OCHIN. She'll present on her study, Patients' Decisions and Perspectives Regarding Healthcare-Based Social Risk Interventions. Next, we'll have Nira Goyle from Nemours Children's Health, and she'll present on group well child care interventions for infants of mothers in treatment for opioid use disorder. And last but not least, we'll have Ellen Lipstein from Cincinnati Children's Hospital, University of Cincinnati College of Medicine. She will present on comparing family decision-making engagement in telehealth versus in-person primary care for children with chronic conditions. Next slide, please. And with that, I would like to introduce our first presenter, Dr. Steves-Reese, who will present on her study, Patients' Decisions and Perspectives Regarding Healthcare-Based Social Risk Interventions.
Thank you so much. Next slide, please. So yeah, hello, I'm Anna Steves-Reese. I'm currently an investigator with OCHIN, but today I'm going to be sharing about my work that was funded by AHRQ through their R36 mechanism while I was a doctoral student at the Oregon Health and Science University, Portland State University School of Public Health in Portland, Oregon. And this multi-method project was called Patients' Decisions and Perspectives Regarding Healthcare-Based Social Needs Interventions, and was comprised of 3 studies, a systematic review, a quantitative study, and a qualitative study. And while the systematic review did include qualitative methods, I'm going to focus this presentation on the AIM-3 qualitative study. And just for context, this project was carried out during the height of the COVID-19 pandemic. Next slide, please. My dissertation focused on social needs screening and referral interventions, which are increasingly common in primary care settings. I use this framework from Gerwich and colleagues to think about how these interventions are meant to improve health outcomes. The problem on the far left is that patients have unmet social needs like food insecurity and housing instability that impact their health and well-being. In response, healthcare organizations first use screening tools to attempt to identify patients' unmet social needs. Next, they refer patients who disclose social needs to resources in the community where the hope is that patients will access helpful resources. If the intervention works as intended, the goal is that patients will have decreased unmet social needs, improved access and quality of healthcare, and improved health outcomes. Of course, this is the ideal scenario. So for all 3 of my research aims, I sought to understand patients' decisions and experiences across this framework, and considering the pandemic and the sudden shift to telehealth, I decided to focus on phone-based social needs screening and referral. Next slide. The manuscript from my qualitative study is called "It Made Me Feel Like Things Are Starting to Change in Society," a qualitative study to foster positive patient experiences during phone-based social needs interventions. And the study had 2 objectives. The first was to better understand the experiences and guidance of patients who took part in a phone-based social needs screening and referral intervention. And the second was to develop recommendations for improving the patient-centeredness of the intervention. Next slide. So the intervention I studied was the Accountable Health Communities, or AHC model, which was developed by the Centers for Medicare and Medicaid Services. And in this intervention, community-dwelling Medicare and Medicaid beneficiaries accessing care at participating clinical delivery sites were screened for 5 social needs: food insecurity, housing instability and quality, utility needs, transportation needs, and also interpersonal violence. And those who screened positive for social needs were offered a community resources summary. Those who screened positive for social needs and self-reported 2 or more emergency department visits within the previous year were offered both a community resources summary and navigation assistance. And I specifically looked at the AHC model intervention in Oregon, which was implemented by the Oregon Rural Practice-Based Research Network, or ORPRN. Next slide. So in the following slides, I'm going to walk through the major steps of our pragmatic qualitative study, including the development of the interview guide, the sampling approach, recruitment and data collection, and our reflexive thematic analysis process. Next slide. Okay, so all researchers and research projects, of course, make assumptions about the world and how knowledge is and should be generated, whether those things are named or not. And pragmatism places emphasis on research that aims to be democratic, collaborative, contextual, and action-oriented, which I think all make it a great fit for primary care research. And for this study, we used a pragmatic paradigm to guide everything from our research questions to our methods and analysis choices. For example, we sought out interdisciplinary perspectives to inform the research process. We took steps to ease barriers to participation, and we centered our analysis on areas in which healthcare organizations may have the most power to both avoid harm and promote healing regarding patient experiences with social needs interventions. Next slide. So for our interview guide, I sought input from my interdisciplinary dissertation committee, ORPRN employees responsible for implementing the AHC model intervention in Oregon, and also a health services researcher who had recruited and interviewed hundreds of Medicaid beneficiaries for a past project. And ultimately, the guide included questions and prompts about participants' health, what they remembered about the screening call, whether and how they made social needs resource connections, and also their insights on what aspects of the intervention went well and what could be improved. And the interview guide was translated into Spanish by an IRB qualified translator. Next slide. So for this study, we decided to use a purposeful sampling approach with a focus on maximum variation. All interviewees had participated in the AHC model intervention in Oregon, and all of them had qualified for and accepted navigation assistance. But we sought to maximize participant variation across multiple characteristics and circumstances for which we had data, including participants' age, sex, race, ethnicity, primary language, English or Spanish, and also highest level of education, and patient self-reported social needs. So this sampling approach had clear strengths and also some limitations. On the one hand, it facilitated the development of themes that transcended a diverse sample. So given that social needs screeners work with diverse patients experiencing a wide range of circumstances, it seemed worthwhile to develop themes and recommendations that would be salient for as many patients as possible. But on the other hand, a maximum variation approach risks overlooking key differences across populations regarding how they experience an intervention and what their recommendations for improvement would be. Next slide. So we received IRB approval from Oregon Health and Science University, and eligible participants verbally consented to participate in interviews. Interviewees received $25 gift cards for their participation, and interviews were conducted remotely. First, I attempted to call each person up to 3 times and used a spreadsheet to track that outreach. I conducted English interviews, and Spanish interviews were conducted by a bilingual and bicultural research assistant. And while the interviews were phone-based, the calls were merged with a Zoom room to facilitate recording and allow for use of the chat function with my research assistant. So next, knowing how many interviews is enough in qualitative research can always be challenging. I use the concept of information power to support with this. So using this concept, sample size is driven by your study aims, the specificity of the sample you're able to recruit, whether you're using established theory, the quality of the dialogue in your interviews, and the analysis strategy that you've chosen. So 34 interviews, our team felt like we had enough information power to be able to make new contributions to the literature around our topic. Next slide. Next, our team used reflexive thematic analysis to develop themes and recommendations from the data. Of course, there's a lot of different interpretations out there for what thematic analysis is. I personally highly recommend the linked resource from Braun and Clark if you plan to use reflexive thematic analysis in your own work. Our team included myself and 4 research assistants, 3 of which had also been screeners for the AHC model intervention in Oregon. First, we created a codebook just for the purpose of enhancing shared understanding across our large team using Excel spreadsheets. Next, the transcripts were analyzed and double coded by me and one of the other 4 analysts in the software program Deduce. Simultaneously, we maintained an Excel spreadsheet to document questions and memos to discuss as a team in regular meetings. Third, I developed preliminary themes, which were iteratively refined with our full analysis team. And finally, I checked our candidate themes against the original transcripts and reviewed them with all co-authors to ensure that they were internally coherent, distinct, and had useful clinical implications. Next slide. Ultimately, our team developed 6 themes from our interviews with 34 participants. First, we found that patients were likely to be initially skeptical or have reservations about the social needs questions. Next, we found that immediate transparency and ongoing respect for autonomy were fundamental. Third, showing kindness for the patient through one's demeanor was very important. Next, demonstrating a genuine intention to connect patients with resources mattered. Fifth, the degree of attentiveness and responsiveness to patient circumstances and requests impacted their experience. And finally, patients could be left feeling appreciative or hopeful whether they accessed resources or not. And in the manuscript, we were very intentional about what quotes we selected to illustrate these themes because we wanted to highlight that the developed themes did indeed transcend a diverse sample. Next slide. So then we used our themes to create a framework for fostering positive patient experiences during phone-based social needs screening and referral interactions. Themes correspond with different time points of the caller-patient interaction. For example, at the starting point of the interaction, patients may rightfully feel skeptical or have reservations. Callers can then take actions to foster positive patient experiences. They can practice transparency and respect for autonomy, bring a kind demeanor, demonstrate a genuine intention to help, and be attentive and responsive to patient circumstances and requests. If callers can put these activities into practice, patients can be left feeling appreciative or hopeful at best, or neutral about the interaction at worst. While the goals of these interventions are usually to connect patients with relevant resources, first and foremost, it's also critical that healthcare organizations train callers on practices that can help with avoiding harm during these interactions. So our hope in creating this framework is that healthcare organizations can use it to inform both screener training and support. Next slide. So in doing some reflecting on lessons learned for qualitative research in primary care, a few key things jumped out to me. The first is the importance of teamwork at all stages of the qualitative research process. There were countless times in which feedback from mentors, colleagues, research assistants changed the way I thought about and approached the study, and many of those individuals didn't have prior qualitative research experience. And further, teaching my research assistants about qualitative analysis both improved my own understanding and was aligned with their professional development goals. Next, overthinking what's right or wrong regarding methods and analysis choices in qualitative research isn't necessarily helpful. When facing difficult decisions, I find it's typically more helpful to come back to the best choice possible given the goals of the study, the collective expertise of the team, and the realities of your context in terms of both organizational priorities and the resources that are available to you. And relatedly, when choices are made, find a way to document them. Transparency underscores rigor in qualitative research and in all research, I think, because it helps reviewers to understand how deeply you thought about an issue and why you made the choice you made to support the goals of the study. And finally, project management and documentation in general are crucial. I used simple Excel sheets to support basically every stage of this qualitative study, and they came in very handy for manuscript writing and accurately reporting what we did. So that's all I have, and looking forward to questions at the end.
Thanks so much. Yes, just a reminder, we're going to save our questions on her presentation until after the other two presentations are completed. At this time, I'd like to introduce our second presenter, Dr. Nira Goyle from Nemours Children's Health. She will be presenting on group well child care interventions for infants of mothers in treatment for opioid use disorder. Welcome, Dr. Goyle.
Thank you so much for allowing me to present today. Again, my name is Nira Goyle. I'm a primary care pediatrician based in Philadelphia at Nemours Children's Health and Thomas Jefferson University Hospital. I have a background in health services research, and my research area, or my research interests really focus on systems of care for newborns and families of young children. And I'm excited to present this work involving qualitative methods because it really represents a departure from my prior research experience, which is largely involved secondary data analysis. Next slide. This project was entitled Group Well Child Care Intervention for Infants of Mothers in Treatment for Opioid Use Disorder. This was funded under the AHRQ-R18 program, which is Demonstration and Dissemination Grants. This was a multi-PI application in which I served as co-PI with my collaborator, Dr. Vanessa Short, who is a maternal child epidemiologist at Thomas Jefferson University. And so this project really represents a collaboration between pediatric researchers and maternal health researchers. As you can see, there were 3 study aims, the first of which was a qualitative study, which I'll be focusing on today, in which we really developed this intervention of group-based well child care for our target population. And then aims 2 and 3 are an intervention study in which we evaluate both implementation and efficacy for our target population based on patient-level outcomes. This was a project that was funded in 2020. We're currently in year 4 of the grant, and aim 1 is complete, and we are now in the intervention part of the study. Next slide. So as a point of orientation, the intervention that this study really focuses on is group-based well child care. So this is an established model of care in which parents and similarly aged children receive routine primary care together, receiving the same routine health assessments and immunizations that they would at any regular checkup. But additionally, it includes components, so parents participate in vital signs and assessments of their child. There is a facilitated group discussion, and then an emphasis on interactive activities, including mindfulness-based exercises. Next slide. So the rationale for aim 1 was really to help inform the design of this intervention and our plan for implementation for aims 2 and aims 3. And we had 3 overarching study objectives for this qualitative aim. What are the opportunities to improve the experience of care for this patient population? What should our intervention be prioritizing in terms of the aspects of care within the intervention? And then how do we best optimize implementation of group well child care? Next slide. So this study, this aim 1 qualitative study, really serves as the foundation for the clinical trial. And the study itself was comprised of a group of semi-structured interviews. As you can see here, we had 2 participant samples. We had mothers who were receiving treatment for opioid use disorder at our academic medical center through the, it's a specific program for pregnant and parenting women. And then we also wanted to interview clinicians who provide primary care to this population. And we included attendings, residents, and nurses from the university-affiliated primary care practice that was located nearby. Next slide. We used a couple of methods for recruitment for the maternal participant sample. We did post flyers in the OUD treatment center, but by far the most effective way was to utilize convenience sampling, meaning we did outreach to the list of eligible participants based on the current roster of the program. So all recruitment, eligibility determination, and enrollment procedures were conducted over the telephone. And for this aim of the study, for aim 1, maternal participants were compensated $50 for study participation. Recruitment of clinicians was conducted through email. We sent an initial email followed by a reminder 1 month later. This was also accompanied by some announcements at our staff meetings. And there was no remuneration for the clinician participants. We did not conduct any propulsive sampling by race or other participant characteristics for either of these study samples. Next slide. We planned sample sizes for this study based on a goal of thematic saturation. So thematic saturation is defined as the point at which your analysis is not providing any additional insights or issues, and further data collection becomes redundant. The available literature on this topic suggests that thematic saturation, the point of thematic saturation is affected by homogeneity of your study sample, as well as how narrowly defined the study objectives are. So based on these issues and available published literature, as well as prior research from investigators on our study team, we planned for a sample size of 30 parents and 15 clinicians, with a plan to enroll additional participants if needed. Based on our recruitment procedures, we ended up with an actual sample size of 31 mothers and 13 clinicians. Next slide. The study procedures for each participant are shown here on the left. All of these study procedures were conducted by telephone. So the participant was first asked to answer a brief survey to provide some demographic information and some information about their healthcare experiences. And then this was followed by a semi-structured interview that was intended to last about 30 minutes long. All of these interviews were conducted by 2 of the PhD investigators on our study team and were audio recorded and then transcribed using a web-based HIPAA-compliant transcription service called Rev. And all of the procedures were reviewed and approved by our institutional IRBs. We were granted a waiver of written informed consent given the nature of the study and the fact that this was all conducted over the telephone. However, we did provide scripts for obtaining verbal informed consent from all of the participants. Next slide. So the semi-structured interview guides themselves were developed using the Consolidated Framework for Implementation Research, or CFIR. So this framework encompasses a list of domains that are thought to influence the efficacy, sustainability, and scalability of an intervention. And the framework can be really useful in a formative approach when first developing the intervention or a plan for implementation. So as you can see here, I'm showing some of the some sample interview prompts and how they map to these CFIR domains. We developed 2 separate interview guides, one for mothers, one for participants, and these were developed and refined really in parallel with each other, which was helpful for us to ensure that that we would be gathering data that was going to be synergistic. Next slide. The thematic analysis for this study utilized an inductive approach, and this emphasizes the experiences, feelings, and perceptions that were reported by participants during the interviews. The entire phase of analysis was led by 2 researchers on our study team, both PhD trained and who have extensive experience with qualitative research. And I can't emphasize enough how grateful I was to them for their thoughtful and rigorous approach to the analysis. There was a lot of data. As you recall, there were 31 maternal transcripts and 13 clinician transcripts. And so 8 of these transcripts, 4 maternal and 4 clinician, were first coded independently by both of these researchers to develop the maternal and clinician code books, which were iteratively refined over the course of multiple meetings with between themselves and their team and our research coordinator to discuss discrepancies and ensure that that there was consensus around code definitions. After this, 9 more transcripts, 5 maternal and 4 clinician, were also coded independently and used to establish intercoder reliability. And you can see the kappa values that were shown here, and these were produced from deduce. And then subsequently, the remaining transcripts were divided between these 2 coders. Next slide. So all of these codes were then organized into emergent themes here. And these were slotted into kind of our overall 3 primary study objectives. So those are shown in those 3 blue boxes. The assets and challenges associated with engagement in pediatric care for this population, priorities for the pediatric visit, and then barriers and facilitators to group well child care implementation. So this was the kind of overarching framework that we then tried to organize all of the emergent themes. The thematic saturation was determined by the investigators, by these 2 PhD researchers as they were coding transcripts. And then after analysis was complete, they were able to conduct a more formal kind of quantitative description of the thematic saturation. And one of the things that they observed was that for the clinician participants, that clinician sample, thematic saturation was achieved earlier than for the maternal participants. Across these 3 kind of study objectives, we made the decision to report maternal and clinician themes together, as we felt that this would provide an opportunity to both describe areas of concordance and discordance between these 2 participant groups, and also allow us to describe aspects that were maybe emphasized more by one group versus another. At the end of these analyses, we conducted we did member checking with 2 mothers and 2 clinicians who participated in the study. And these participants confirmed that our reported findings were generally consistent with their experiences. And the sort of researchers who led the qualitative aspect also held debrief sessions with our entire research team, which was comprised of clinicians and other researchers with additional kind of research expertise. And this allowed us to really assess content validity and help to provide clinical interpretation to the findings. Next slide. So here, again, are those 3 overarching study objectives listed in blue with all of the emergent themes that were identified from these analyses. So as you can see, for an example, the box at the bottom was our objective of understanding facilitators and barriers to group well child care implementation. And as you can see, there were 6 facilitators and 6 barriers that emerged from the thematic analyses. Under facilitators, having the intervention focus on maternal opioid use disorder and recovery, as well as having an opportunity to provide peer support, were viewed as facilitators. And then the intensiveness of resources required for this intervention and potential loss of privacy emerged as potential barriers to implementation. Next slide. Here you can see some of the representative quotes that were used to develop the themes. And so as we reported these findings, we were really intentional about pulling out representative quotes from both maternal participants and clinician participants that mapped to these different themes. And again, we were also able to describe in a narrative way which were more emphasized by participants and where there might have been areas of discordance between the 2 samples. Next slide. So we are currently in the process of conducting the the next phase of the study, which is the intervention study. In AIM-2, we are evaluating implementation of this intervention. Shown here is a flyer from the intervention phase of the study, which we were calling CHAMPS, Child Healthcare at Mater Pediatric Study, which we are still actively enrolling in. So we have plans for both a formative and summative evaluation of implementation. And this includes a mixed methods approach for implementation or evaluation of implementation. So we will be collecting quantitative data, but also qualitative information through interviews with participants who've been randomized to the intervention arm. Next slide. In terms of takeaways from this experience, I think it's been really important to underscore the importance of patient voice. The information gleaned from these patient and clinician interviews have really grounded this research and have allowed us to really match this intervention and our plan for implementation to the care preferences and priorities for our target population. So this is a process that we plan to continue to utilize it through the next phase of this study, but I think will also be an important approach that I try to integrate with future research projects as well. Sampling approach is an important consideration that I wanted to highlight. We did not conduct purposive sampling. And it's both important to acknowledge in the design phase of the study, so when you're sort of planning the study, as well as on the back end when thinking about interpretation of findings and dissemination, to consider how sampling impacts both the homogeneity of your sample and the application of study findings to other treatment settings or to other populations. I personally found the CFIR framework to be super helpful. I think in general, having a framework to guide the evaluation process for an intervention like this that's so complex is really helpful to keep us organized and also just added rigor to our overall study. Multidisciplinary teamwork, I think, just to repeat what Dr. Steves-Reese was saying before, as a clinician, I really relied on the expertise of my collaborators who have expertise in population health, epidemiology, and qualitative methods to successfully execute this project. It was, I think we all really had an important contribution. And then finally, again, as somebody who has more of a background in quantitative research and secondary data analysis, I found, not surprisingly, that qualitative research, there are some unique considerations when it comes to dissemination and publication. And so again, I think really relying on the experience of my colleagues with qualitative research was really helpful and allowed us to package our findings and target them to a readership and to an audience that we really wanted to get this information to. So I'm happy to take questions at the end of the session, and thank you very much.
Thanks so much. Before we move on to our third and final presentation, I just wanted to thank everyone's flexibility. We know there's been a number of questions about closed captioning, as well as transcript, as well as a very spirited commenter. So I just want to say, working as a representative app, working with Amy and her colleagues, the National Center for Excellence in Primary Care Research, we absolutely strive for very pragmatic, relevant, constructive, and harmonious learning environments. So thank you again for reaching out to us via comment and email, and for just joining us on this journey here as we do a webinar with lots of folks. So with that, I'd like to introduce our third presenter, Dr. Ellen Lipstein from Cincinnati Children's Hospital. She will be presenting on comparing family decision-making engagement in telehealth versus in-person primary care for children with chronic conditions. Welcome, Dr. Lipstein.
Great. Thank you so much to AHRQ for the invitation to speak today, and more importantly, for the funding for this work. As a little bit of background, like Dr. Goyle, I'm a primary care pediatrician clinically and trained in health services research. My research has focused on shared decision-making, particularly shared decision-making for children with chronic conditions and how we engage adolescents and children in that decision process. And I'm really excited to be doing this work, which is funded by an AHRQ-R01, because it's an opportunity to really merge my research and clinical passions. Much of my prior research was in the subspecialty world, and so it's great to have this opportunity to do primary care work. Next slide, please. The impetus for this work, as everyone is probably well aware, is the widespread implementation of telehealth during the early parts of the COVID-19 pandemic, particularly to new clinical areas such as primary care pediatrics. And telehealth continues to be widely used, though slightly less so than it was earlier in the pandemic. There's evidence that the communication and structure of the healthcare interaction is different in telehealth compared to in-person care, but it's unknown whether the quality of care is equivalent despite those differences. And yet, telehealth continues to be offered with the assumption that the care quality is equivalent. And we would anticipate that any impact on quality of care is particularly relevant for children and adolescents with chronic conditions, given their increased use of both telehealth and in-person care. So that was the impetus for this study on comparing decision engagement in telehealth versus in-person care. If you move to the next slide, please, you'll see the conceptual model operating behind the study. And that is that we're grounded in decision-making and telehealth frameworks, especially the Ottawa Decision Support Framework and Monica Peak's work on shared decision-making in minority communities. And so the crux of our data collection is focused on that shared decision-making interaction between a family and a clinician, with an expectation that whether the care is delivered via telehealth or in-person care likely impacts that, as does a lot of other factors, as you can see surrounding that blue square, which represents the social context in which the care is taking place. The outcomes we're interested in are satisfaction, healthcare outcomes, and satisfaction with decision making. And this is a good point for me to pause and interject that unlike the works by Dr. Goyle and Dr. Steves Reese, we're very early in this project. We're less than a year into the funding. And so I'm going to be talking about our plans and what we've started, but I have no data to share with you today. If you move to the next slide, the overall objective is to compare the decision-making processes and outcomes between telehealth and in-person pediatric primary care for children with chronic conditions. Today, I'm mostly going to talk about aims 1 and 2, and our mixed methods approach there. And those are focused on comparing the effectiveness of telehealth to in-person primary care on perceived and observed shared decision-making and clinical outcomes. Whereas aim 3 will be a qualitative aim to develop an in-depth understanding of the decision-making process in telehealth compared to in-person care. Next slide, please. This slide presents an overview of the study. Aims 1 and 2 are happening concurrently. Aim 1 is a purely quantitative aim using surveys and medical record abstraction to look at outcomes. So we're asking about perceptions of shared decision-making, as well as looking at clinical outcomes from the medical record. Aim 2 is video observation of telehealth and in-person visits. So we are video recording those healthcare visits, and then we'll be analyzing the data, as I'll show in a future slide. And then aim 3 will be a qualitative aim in which we'll do interviews with parents, adolescents, and providers. Next slide. Our study sample is shown here. We're including primary care clinicians, pediatric primary care clinicians who do both in-person and telehealth visits for families of patients ages 5 to 17 who are being seen for asthma, ADHD, or eczema. In the interest of thinking about the audience and the focus of NICE PCR, I should say that this work is only to date including pediatricians, and that has to do with the fact that we are using because of the telehealth that we're using and recording those telehealth visits. And at least locally, in my interactions with family practice physicians, most of the family practice physicians that are using telehealth are doing it for homebound adults, not for pediatric primary care. And then for the families who are recruited, for the video part of the data collection, parents consent and children and adolescents assent to participate. For the surveys, if the patient is age 5 to 11, we are only collecting a survey from the parent. Whereas if the patient is age 12 to 17, our goal is to collect separate surveys from both the parent and the patient. As you might imagine, we have a lesser completion rate for the patients. Next slide, please. So before I talk a little bit more in depth about our mixed methods, I want to talk a little bit about some prior work we did that informed the methods for this study. So previously, as I mentioned, I did a lot of work in subspecialty spaces, and we did work in which we had video recorded actual clinical encounters in gastroenterology and rheumatology, pediatric clinics both, around a specific treatment decision. And then we used kind of a structured qualitative analysis to look at components of shared decision-making that occurred in these visits. So we used what was then called the model for clinical practice and is now the 3-talk model of shared decision-making, which is shown here in the ovals of choice talk, option talk, and decision talk. The bullet points underneath that represent the different components of each of these talks. And we've color-coded them with green representing something that was done in nearly all of the visits, which was listing and discussing options. Blue is something that was done in some of the visits, and most often that was done in 2 to 3 out of the 20 to 30 visits we recorded. And red was something that was done in none of the visits. And so what you can see here is that a lot of components of shared decision-making were not done at all in this prior study in subspecialty visits. So if you move to the next slide, that led to us wanting to use a mixed methods approach, this prior experience, to these aims. So for the shared decision, for the observed shared decision making, so this is what comes from the video encounters, and by observed, it's not that we're observing it in real time, it's that we're recording it and then looking at observing what's in those recordings. We're doing a quantitative measure called the option 5, which is a validated measure of shared decision making. But because of our prior work, we were concerned there could be a floor effect and we would not be able to see any differences. So we will additionally be doing some content analysis of the recordings, kind of similar to what I showed color code in the prior slides, to look at qualitatively what's happening in these visits, telehealth and in person. To do that, just for a little methods information, we'll actually have the key components of the videos transcribed. The coders will review the videos so that they get to see them for themselves, the nonverbal content, they get to hear the tones of voice, but the coding will be done from transcripts. The reason we do that is because in prior work we learned that coding is hard from transcripts and coding is hard from videos, excuse me, and analyzing that coded video data is actually really cumbersome. And so we found that coding from the transcripts and then referring back to the videos as needed was preferable. And then, as mentioned, the other part of this study, these aims, is quantitative work on perceived shared decision making. So what the parent and the adolescent perceive the decision interactions to be, and that's based on survey and then medical record review for health outcomes. Next slide, please. Aim 3 is purely qualitative, using a sequential explanatory approach in which the goal of the qualitative data is to explain, elaborate, or give contextual depth to the quantitative findings. And so what we'll be doing is looking for areas for future intervention development. How do we improve whichever modality has less decision engagement? Are there types of chronic condition visits that are more appropriate for one modality for the other? And how do we address any inequities we find in this study? Next slide, please. For this, we'll be doing individual interviews with parents, adolescents, and healthcare providers. Initially, we'll do purposeful sampling to get people who have experience with both telehealth and in-person care. So some people who have experience with both and some people who have experience with only one or the other. And then we'll use snowball sampling to be able to feed this data forward and get input from providers and families who use telehealth outside our hospital system. And for those of you unfamiliar with snowball sampling, what's done there is you ask a participant in the study to connect you to someone else who might qualify for the study. So in this case, we would start with the providers and ask them to connect us to their colleagues in other healthcare systems that are using telehealth. And then we would ask those participants to connect us to patients of theirs who are using that telehealth system. Next slide. To highlight some of the benefits and challenges of qualitative work overall, but that connects to why we did it for this study. It's great for exploring understudied areas. Nothing kind of gets under my researcher skin more than survey data that is clear that they didn't do their prior work and they just kind of guessed about what they should ask questions about. It's great though for informing that future quantitative work, whether it's intervention development or survey work. And as highlighted with the prior work, it can address kind of what I call deficiencies in quantitative approach. So if you know there's going to be a floor or anticipate there may be a floor or ceiling effect from a measure that you want to use, adding some qualitative data can really enhance that, work. As for challenges, it's very time and labor intensive. I'll say I often have residents or fellows come to me and say, oh, I have this idea and someone suggested I do a quick interview study. There's no such thing as a quick interview study. It's not generalizable. I'd say that's a challenge, but definitely not a limitation. Qualitative work is not designed to be generalizable. It's designed to get in-depth experience so that you can then move to the quantitative work that's generalizable. And in some areas, it's not well understood, which can lead to some funding and publication challenges. Luckily, AHRQ has been a big supporter. Next slide. To wrap up, for some potential next steps for this work, as I mentioned, we want to do some intervention development. We may do some comparison of telehealth and primary care to specialty care. And finally, looking at the role of additional technologies, particularly in the telehealth space. Some of our clinics are starting to use a device that allows us to listen to heart sounds, lung sounds, look in ears, some of those things that previously were only available for in-person care. And we can anticipate that may impact both the decision-making and the health outcomes. And finally, I was asked to talk a little bit about some reflections of my growth as a qualitative researcher, and I would define myself as a reluctant qualitative researcher. I did my first qualitative study as a fellow about 15 or 16 years ago and hated it. I thought I loved doing the interviews, but I thought coding was really cumbersome. It was hard to get published. It was just kind of a drag. But it turns out that necessity is the mother of skill development. The areas of research I've been interested in, particularly around pediatric shared decision-making, has been very understudied. And so I had to learn and to work on the skills of qualitative work. For those of you who are more junior in your work, what I've come to learn is that as you get more senior and have more money, with growth in your team, you can delegate some of the aspects. So for instance, with this study and with others, I have graduate students and research fellows who are helping with some of the coding and analysis, which lets me focus on the grant thinking and manuscript writing that is part of what I like better. And there's also benefits to having some specific methodologic expertise in this time in which we are all struggling to maintain our funding. Having qualitative methods expertise has allowed me to occasionally serve as a methodologic consultant on some studies, which can be helpful to diversifying my portfolio. So I thank you all, and like the others, I'm very excited to participate in some question and answer. Thank you.
Thanks, Ellen. We've also been monitoring the chat, and we have one question that I will be asking after I pose a methods one. And I also encourage folks to read the chat because there's been a lively discussion about various terminology around what was previously mostly described as snowballing. A lot more people are using different terminology: chain, network, respondent-driven, chain referral. So I encourage you to look at that. And if we have time, we will return to that, but we have several methods questions to ask. So before I ask one from Sarah T, which is teed up, I would like to ask all three of our presenters who provided such a rich set of presentations that I felt very much complemented one another. My question to you, and I'm asking our colleague to post in the chat right now so everyone can process it visually, is that NICE PCR, or otherwise known as the National Center for Excellence in Primary Care Research, is committed to building the primary care research workforce, including clinicians, clinician researchers, as well as scientists from other disciplines. We understand that you've engaged and continue to engage a multidisciplinary team at different stages of the research. For example, conceptualization, data collection, analysis, interpretation, and dissemination and sharing of study findings. So how would you best characterize your efforts collaborating with, training, and learning from a multidisciplinary team to help build this primary care research workforce? And I'll turn to Anna first because you presented first.
Thank you for that question. Well, I think first, just because of the nature of qualitative research, I feel like the process allows whoever's involved to take a step back from day-to-day practice to think really deeply about a topic from multiple perspectives. And I think especially if you have an interdisciplinary team that's involving multiple members of a care team, and even patients or, student researchers, it just allows you to think about a process within the primary care context more deeply, and think about like how you'd want to change something or address something as a team. So I think it can be really important for development in that sense. And then I don't know if this is specifically addressing your question, but I think that like when you're trying to identify like what individuals to bring into that process, like what I try to do is just have a lot of different conversations across the Oregon Rural Practice-Based Research Network to understand like what employees have an interest in qualitative research at all, and what people are doing work that would benefit from qualitative research expertise in the future, and then try to work with those people so that one, I didn't have to budget them on my research because what they were doing aligned with other projects, which was very advantageous for everyone. So just thinking about, bringing people in that have a natural interest and they could anticipate that their future work would, benefit from qualitative methods. So I think just like being strategic and how you're thinking about the qual team.
I'll add, as a clinician, I think there are, as Dr. Lipstein was alluding to, there are a lot of competing priorities and pressures for our time. And, I think I have really evolved in my thought process around my own approach to research and funding, just, the importance of collaboration with folks that have kind of less of those time pressures and and whose really focus is research. And I think that complementary expertise, I feel like I can lend clinical insight into these research questions. And then again, the sort of the rigor and the expertise around some of these methods they can provide. And so it's a really really important partnership. I would not have gotten this AHRQ grant without Dr. Short. She wasn't able to attend this session today, but she, it was instrumental to have her working with me.
To add to what I totally agree with everything Dr. Goyle and Steve Zariz has said, but also two things that I think have helped for us. One is part of our multidisciplinary team, really on more of an advisory space, but is members of our clinical team. And so having them understand research more, I think ultimately leads to growth of primary care research because they're more open to it happening in the clinical spaces, and they're more open to thinking about how they could be participants. They're more open to coming to me and other researchers when they have research questions rather than trying to just push forward without answering those questions. And so I think that's helpful. And also, I'll just say that a lot of our work for this study is happening in clinics that have residents who didn't know what I do when I'm not in clinic. They kind of think you're a full-time clinician or that you only work part-time. And so as a clinician scientist, I think it's helpful for the research to be happening in their clinical spaces. So they get to know about these opportunities, and that if you want to be a researcher, you don't have to become a subspecialist.
Thank you. That's very helpful. I'm going to pose one other question, and then I have a question that's directed for Dr. Goyle, another one for Dr. For the shared Dr. Epstein. But before I do that, I want to post one other question here, and then I'll ask it out loud. And that is, multi and mixed methods research rests on the logic of triangulation, seeking the convergence of results under different methods, recognizing that timing of this convergence really depends on whether the study is a convergent, explanatory sequential, or exploratory sequential design. So more broadly, because I know you're all working at different times, phases of your own work, and have different study designs, but what were some of the challenges and fruitful outcomes? And in Dr. Epstein's case, I know this is more future forward, but I know you've done a lot of mixed methods. So just talking through triangulation and challenges and fruitful outcomes. And Anna, could you go please first?
Sure. Yeah, so my experience was interesting because my project was meant to be an explanatory mixed method study. So initially I had a quantitative aim, and I wanted the qualitative aim to help kind of explain and deepen the understanding of the quantitative aim. And to a certain extent that happened, but not in the way that I anticipated. And I think that a lot of that was due to just once you actually get into the quantitative data sometimes, or once you get into the study, and also once a pandemic happens that you can never anticipate, the way that different aims come together isn't exactly what you could predict. But I still, I ended up redescribing my work as multi-method because I still was using different methods, basically to address different kinds of questions related to social needs from the patient perspective, using the Gerwich framework that I shared. But one thing that was interesting, so for the quantitative aim, I ended up looking at also basically remote versus in-person screening, and whether that was an effect modifier for whether or not patients accepted navigation services, based on the total number of social needs that they reported. And in that paper, I basically found that remote versus in-person screening was not an effect modifier, which I think was encouraging for people that are doing social needs screening and referral remotely. But then the qualitative work, I think, really underscored that, well, with our particular study, I think that we did a really good job at training screeners around like how to use trauma-informed care, and screeners had a lot of time to talk to patients. And there were a lot of things about our study that I think made the phone-based screening go better than it may go in other ways. And so, but that wasn't really brought together in one manuscript. So anyways, I would say that in conclusion, it's just always messier once you're actually getting into the nuts and bolts of like how to bring it all together. And I think you have to use creativity and like just really assess your context and figure out, like, does it make sense to stick with the initial plan, or would it actually be more meaningful to approach the multi-method or mixed method study from a different angle?
When I think about triangulation of findings, there were sort of two ways that I think about this. We had conducted some quantitative research, leading up to this qualitative study, where we had described, adherence to well childcare and missed visits in this population. We had also done some survey work with both clinicians and parent participants, all of which sort of, I think, helped seed questions for the semi-structured interviews, and I think really deepened our understanding of some of these findings that we observed in the more quantitative studies. We also had triangulation between parent participants and clinician participants in our study, and I think the beauty of these qualitative studies is that you're really able to kind of describe in a narrative way some of these differences and similarities. And we ultimately found quite a bit of convergence around the emergent themes for these two groups, but where there were areas of not necessarily disagreement, but just differential emphasis, that was really helpful for us to learn about as well, and helped us to be thoughtful in terms of how we would integrate some of that information into the intervention. So, for example, something like time constraints, that was like a universal, everybody agreed that time is limited and there's not enough time to get through all of the information. But something like whether maternal OUD treatment status and where patients are in their recovery journey, there was more variable information, like more variable perspectives on that topic in terms of clinician comfort level, feeling like that they were knowledgeable enough to be able to address that in well-child visits. And then similarly, moms reported a potential willingness to discuss that information, but also had concerns about feeling judged and feeling like, they didn't want to be necessarily compared with other participants in the group. So it's really rich information, I think, and it's unique to qualitative research.
And I can talk very briefly, so we have time for other questions, but about some of our prior work. I think what's been really fruitful is understanding the differences between what people state is happening and what's happening. So some of our qualitative video observational work came from out of survey data, or was coupled with survey data in which clinicians and families were both reporting families were reporting wanting shared decision making, and clinicians were reporting that it was their preferred approach. But then when we had this qualitative video data that really helped us understand what was going on, it let us understand that there's a lot of unanswered questions there. So really it was fruitful in thinking about next steps in terms of where is the discrepancy. It's not that people don't want to do shared decision making in this case. It's probably that they don't understand what shared decision making is, or operating under a different model. And so being able to bring these quantitative and qualitative work together has helped us think about next steps in that work.
Thank you. So as moderator discussed, and I'm trying to blend the methods-based questions that we're receiving and also planned out, and also sometimes some that are a little bit more practice-oriented that are coming from the audience, which we love as well. So I'm going to try to blend that for the rest of the time. And Ellen, if you could build off of what you just said, I'm going to pop in a question we received so everyone sees it again. So it's the very bottom of our chat. It's in the shared decision-making study, how are you addressing limits on SDM before they occur or after? What limits have you named?
I'm not totally sure what the person means by limits on shared decision-making. In this particular study, what we're doing is we're not doing any intervention at all. We are just looking at what happens in these clinical interactions, and then measuring both through observation, as we discussed, and then through the decision process scale, what actually has happened. So I apologize that I don't understand more specifically the question, and I'm happy to have that questioner or anyone else reach out to me for further conversation.
Thank you. Yeah, and as much as possible, the questions that I'm posing, I'm selecting that I feel have an element of research or evaluation. So Anna, I have a question from one of the audience members I'm posting in the chat as well, which is, would love to hear about how we can leverage existing programs around social determinants of health and projects, especially in the evaluation process.
Yeah, that also might be helpful to clarify a little bit, but I'll do my best. Yeah, I mean, I think there's so many organizations that are implementing these types of interventions right now. And, you know, for a bunch of reasons, I think there's been a growing interest in it in general, but there's also way more financial incentives to start screening for social needs. And so a lot of, you know, practices are having to do this, whether or not, you know, they feel like they have capacity or they're ready for it. But I think that there's there's so many resources out there for thinking about what to evaluate and how. I think SIREN, the Social Interventions Research and Evaluation Network out of UCSF, have excellent resources on different screening tools, different aspects of social needs screening and referral to think about. One of the other papers that I wrote under this AHRQ-funded project was focused specifically on the specificity on, you know, naming what you're evaluating. One of the things I found in my systematic review that when it comes to social needs resource connections, there's often not specificity around like what a resource connection actually is. For example, like, is it a referral? Is it, you know, a patient connecting with a resource in the community? Is it them actually, you know, enrolling in SNAP or like getting some kind of a benefit? And so I think that one thing to just think about for SDOH intervention research is like, what are you actually interested in, you know, and defining that really clearly in order to inform the whole study. And I think way more involvement from patients throughout that evaluation is needed across a lot of SDOH research. So to the extent that advisory boards, especially for community health centers, could be leveraged to get that input, I think that that's really important for those kinds of interventions, and also community-based organizations to the extent possible.
Thanks for that rich response. We're almost at time, and I would like to finish out this webinar with a more methods-based question for all of you. And Nira, I'd love for you to start us off. And it's an audience question, which is audience member question. What further training do PIs need to conduct more robust qualitative research, or to be beneficial to collaborate with experts with this research approach? For example, medical anthropologists, medical sociologists, etc.
Yeah, it's a great question, and I'm a little bit I have mixed feelings about it, to be honest. I think that to some extent, you know, it's one of these things where you don't necessarily have to have, you know, this formalized training, as Dr. Steves-Rees mentioned. I think that there's space for a variety of experience levels in all forms of research. Our own team, we incorporated quite a few medical students who it was their first exposure to qualitative research, and they really added a lot of value to the project and are really instrumental in getting things done. So I think, again, speaking from my own perspective as a clinician, I do have master's level training in research methods, which included what I would call probably a crash course in qualitative research. But I do think that just given the continuing evolution of like this field of this type of line of inquiry, and the fact that methods are continually sort of evolving, and there's a lot to know, and it's not easy to conduct this type of research. It's not a quick, you know, one-off study that is easy. You know, I do think partnering with folks that have dedicated time and expertise can be really important and really helpful. I don't think it's, you know, is it absolutely necessary? Maybe not, but I do think it's incredibly helpful and adds to the rigor of the research and likely the validity of your findings.
Okay, yes, please.
I was gonna say, I can add, I think that who you want to collaborate with often depends on, not surprisingly, on what your research question is and what approach you're wanting to use. You know, an anthropologist uses a very different approach than a sociologist, for instance. But I think for people who are looking for more training, there are a lot of good options. There are some summer intensives, you know, week-long or month-long summer training programs that I think can be very helpful in gaining skills and gain, sometimes even just as much as like gaining the resources and the language to speak about qualitative work can be really helpful. And then I think if it's something that people want to really learn about as much as it's good to have a collaborator who leads the work, such as Dr. Goyle's had, but I think it can also be good to just work with a collaborator so that you learn the skills and then are able to grow your own expertise in that space.
Wonderful, thank you. In the interest of time, Anna, I am not going to ask you to chime in if that's all right. Very much appreciate your contributions along the way. Well, I want to thank all of our three esteemed presenters today, and for all of you who have joined. This webinar and its slides with captions will be available on the AHRQ website in the near future. And please stick around to take the short evaluation poll that will pop up after the webinar. Thank you.